Good morning, and thank you for joining us for the 12th Annual Don Ricks Distinguished Keynote Address. My name is Sally Greenwood, Vice President, Communications and Societal Engagement at Genome BC. We are broadcasting this morning from downtown Vancouver on the traditional, ancestral, and unceded territory of the Coast Salish people, the Musqueam, Squamish, and Tsleil-Waututh nations, who have been custodians of this land for thousands of years. After 20 months of this global pandemic, we had hoped to be visiting with you in person, or at least through a hybrid event. Sadly, despite great progress on the vaccine front, this menace known as SARS-CoV-2 is still in charge, and we meet again virtually. A special welcome to the high school and university students from around the province and beyond. You are the researchers, teachers, artists, business leaders, physicians, and entrepreneurs of tomorrow. Like the generations before you, it is your aspirations that will provide the new innovations and opportunities that will benefit future generations, much like Don Ricks, the person for whom this event is named. Don Ricks was an innovator and a philanthropist with a broad palette of interests: medicine and science, education, and the arts. He was a recipient of the Order of Canada, the Order of BC, and one of the co-founders of Genome BC. Don believed that technology and innovation were the fundamentals upon which to build the future of British Columbia. In a speech to the Vancouver Board of Trade, Don explained that technological innovation transcends all boundaries. He said, "Not only does it create new industry sectors and new jobs, which in turn boost economic output, it also provides traditional industries with advances that allow them to be more productive and competitive. Most importantly, technology improves every aspect of life by coming up with new ways to address important social issues." Don was a visionary and a pioneer. Throughout his life, he looked for gaps and created opportunities to fill them. As a physician, Don saw the need for better diagnostics and helped to co-found a system of clinical labs across Canada, better known today as Life Labs. He had a keen interest in biotechnology, and as the chair of our board through our formative years, his influence on the development of Genome BC is still felt today. We should never lose sight of his vision or his spirit of collaboration. This has guided our trajectory for more than 20 years. After losing Don in 2009, we established this event as a way to recognize his legacy and inspire our community. Today, we are delighted to bring you the unique perspectives and insights of Professor Dame Sue Hill, the Chief Scientific Officer for England. Before I ask Dr. Pascal Spothelfer, Genome BC's President and CEO, to introduce our distinguished speaker, there are just a couple of things to know about today's program. Following the presentation, there will be a Q&A session. You may use the Q&A panel on the side of your screen to ask your question anytime throughout the talk. You can also upvote questions as they appear, and we'll draw upon those most popular during the Q&A session. After today's talk, we invite you to participate in a virtual reception in the networking hall through our website. This is an open space where you can connect with your fellow participants to discuss the event or make new connections. You can also participate in the social conversation on Twitter by tweeting using the hashtag DRDK2021. And with that, I'll hand it over to Pascal to introduce our speaker.
Thank you, Sally. And thank you for joining us for this morning's Don Ricks Distinguished Keynote with Professor Dame Sue Hill, the Chief Scientific Officer for NHS England. You can find details about Dame Sue and her long list of achievements on the event's website. What makes Professor Hill such an outstanding DRDK speaker is her leadership across health sciences, genomics, and health policy. All of her competencies were and continue to be an essential part of the UK's and NHS England's response to COVID-19 and will be equally important to formulate the future of pandemic preparedness in the UK and England. Sue is also a key driver for NHS England's world-leading deployment of genomics in the healthcare system. The way the NHS is bringing genomics into the clinic under her guidance is truly remarkable and will serve as the blueprint for many other healthcare systems that are well behind in these efforts. We have had the pleasure to collaborate with Dame Sue and many of her colleagues in England, including Genomics England, for many years. We have come to appreciate her depth of knowledge, her strategic thinking, her ability to connect and to collaborate, and I'm thrilled that Sue accepted our invitation to speak to you today. Ladies and gentlemen, I'm pleased to introduce to you now Professor Dame Sue Hill for the 2021 Don Ricks Distinguished Keynote Address.
Thank you very much, Pascal. Thank you, Sally, and thank you, Genome BC, for the invitation to give this prestigious named lecture in honour of a truly remarkable innovator. And a huge welcome to everybody who's joining this lecture this afternoon. And please do ask me questions or get in touch with me after the event. If I could go to my first slide, my second slide now. What I hope I'm going to say to you today is that the fundamentals of technology and innovation and entrepreneurship, which is what Don Ricks actually promulgated, is also what we're trying to do in England and across the UK in terms of genomics. So using technology and advances in technology and other innovative changes to build a future, and to build a future that gives us a better healthcare system and a better healthcare outcome for our patients and our public. If I can go to my next slide just sets out that as part of a review that was undertaken by Eric Topol, who's a well-known cardiologist on the west coast of the States, his comment in a review of what technologies were really going to make a change in healthcare and where we needed to develop the workforce more systematically was that genomics was going to be the biggest breakthrough of the last 50 years. And that for many years, although, and indeed for over 100 years, medicine has been talked about in terms of personalisation. But we're really starting now to have the tools, the technology, to be able to make this a reality for people. And this is based on recognising that everybody is, as an individual, is unique. And it's how we actually personalise against that uniqueness using cutting edge technology and using the latest analytical techniques. If I can go to my next slide. My next slide just sets out the strategic approach that we've had in the UK and in England to genomics and genomics in healthcare. My next slide just sets out that we've had a long history of academic discoveries in the UK, all related to genomics, starting back, and there may even be earlier times than this, with Charles Darwin, who published The Origin of the Species. Just for those of you, and as a side note, I live in the Midlands, and I live not very far away from where Charles Darwin spent some of his time in Lichfield, and where in Lichfield Cathedral there's a monument to Charles Darwin. But through to Watson and Crick and the discovery of the structure of DNA in 1951, to Fred Sanger, who the Wellcome Sanger Institute in Cambridge is named after, who established the technology for DNA sequencing, then subsequently to Alex Jeffreys in 1984, who set out the technology for DNA fingerprinting, so important in health but also in forensic applications. And then in 1997, Dennis Lowe, before he moved back, he moved out of the UK for particularly circulating tumour DNA associated with NIPT. And you've just seen in the slides leading up to the start of this lecture how important non-invasive prenatal testing is. And I think just as an interesting fact and things that people don't always realise is the UK has fostered more than twice as many Nobel Prizes for medicine and physiology per capita than anywhere else in the world. And some of these key people who've led us to our long academic history in genomics have been part of that. If I can go to my next slide, that history, that academic background has led us to having a world-leading position in genomics, whether it's the UK's contribution to the Human Genome Project that came out of the UK, took 10 years to complete, and UK facilities, including now those on the Wellcome Sanger Institute campus in Cambridge, were critical to this contribution. And then on to the 100,000 Genomes Project announced by the then Prime Minister as a way in which we could look at a paradigm shift in the way the NHS used genomics, and I'm going to come back to that, through to the NHS England board in 2015 announcing a strategic approach to personalised medicine using genomics at the core, but as one of our strategic approaches to making the NHS one of the advanced systems, healthcare systems in the world. And then in October, when we launched the NHS Genomic Medicine Service, and then in November, as we started our first live testing of whole genome sequencing as part of our routine diagnostic sequencing. And then finally, and something that I'll come back to, is the contribution the UK has made to the sequencing of the SARS-CoV-2 genome, where we've shared now 1.2 million genomes into the Global Initiative on Sharing Avian Influenza database. So really not only a world-leading academic position, but a world-leading application position. And if I go to my next slide just sets out that this has been supported by political and strategic buy-in, not just over the last 10 years, although this slide at the top indicates all the policy and strategy documents that have been developed and published from the government or from within NHS England that is now, it was at one point part of government, but it's now an arm's length body operating under a mandate to the Department of Health and Social Care. But this commitment to genomics through different government papers, different investments, has been there for over 20 years. And you can see at the bottom, there's a number of key commitments around genomics, some of which I'm not going to talk about today, but that's included the genomic sequencing that's happening within the UK Biobank project, the 5 million early detection cohort that will be established more focused on preventative healthcare, as well as all the work that's being done in conjunction with Genomics England, that is a company that is owned by Secretary of State for Health and Social Care in England, with a number of different investments, which I'll come back to, around newborn sequencing, around cancer technology and diversity. And not forgetting, of course, the contribution that the government's made in terms of viral sequencing and the research that's been done in a number of different studies, including genomic. So a real commitment, a commitment from the very top, and that commitment has been associated with investment. If I can go to my next slide just sets out the current strategic direction for genomics. If we take that previous slide I've just shown you, to say within the UK, one of the things that we want to do is to stimulate the UK life sciences industries. And the life sciences vision was published earlier this year, but it follows several different strategy documents about developing and focusing on how we can make our life sciences industries world leading, and the UK the place to come and do discovery and our research and development work. A 10-year genomics strategy was set out in Genome UK, which was published now just over 14 months ago. And it set out a 10-year vision about how we'll achieve progress in genomic medicine across three main pillars: across diagnosis and personalised medicine, across prevention, and across research. And an implementation plan has been published to drive the delivery. And the important thing about the delivery of Genome UK and what is set out in it is that there's no new money. It's using the money that's already in the system that has been set aside for investment in genomics, in wherever that might be, to come together in an ecosystem and to drive forward the aspirations that everyone signed up to. This is chaired in terms of the implementation sort of oversight by one of the ministers for health in the Department of Health and Social Care. But it's an ecosystem that will drive the delivery of Genome UK. Very specifically about how it would be delivered in terms of healthcare, that's very much linked to the National Health Service in England and the health services in the other countries of the UK. In particular, in the NHS in England, a couple of years ago now, the long-term plan was published with a number of different genomic commitments, recognising the challenges that we have in terms of delivering a sustainable healthcare system that provides value for money, that is responsive to our populations, that has quality at the core, but that recognises that people are living longer and living longer with non-communicable diseases like cancer, for example. But in the long-term plan, there was a commitment, along with the funding commitment, to sequence 500,000 whole genomes by 23-24, focused on all children with cancer, seriously ill children that may have a genetic disorder, as well as a small number of different cancers that I'll come back to, with extended access to molecular diagnostics for people with cancer and expanding over time, with more genomic testing for a common disease called familial hypercholesterolemia, where people have high circulating levels of fat in their blood, and I'll come back to that, but also a commitment to linking and correlating genomic clinical data and patient data. And through this, improve the recruitment to clinical trials and further support research, and to drive data-driven improvements. And in each of these commitments, it was aligned with other priorities for the healthcare system, particularly in cancer to improve survival rates, in rare disease to diagnose rare disease earlier and reduce the diagnostic odyssey, and in cardiovascular disease, for example, in one area, to reduce those people who die from cardiovascular disease much earlier than they should be, so that preventable mortality. If I can go to my next slide. My next slide just says, this summarises all the genomics that can drive improvements for patients. It can deliver earlier diagnosis, much earlier, and open up earlier treatments. It can provide a more precise diagnosis to link to more effective treatments. It can be used to understand how people can have fewer adverse drug reactions to treatments. It can drive eligibility for clinical trials and informing discovery, and particularly in a more equitable way. And it can identify predisposition markers to enable us to take a more preventative approach. So all key strategic aims for the healthcare system moving forward. If I can go to my next slide, this just sets out that essentially what we're trying to do in terms of maximising the value of genomics for patients in the NHS in England is to really capitalise on the availability of the technology, including using whole genome sequencing to sequence all 3 billion letters in the genetic code of ourselves or people who are suspected of have genetic disease or of cancer tissues, but also couple that with an overall testing strategy where we might look for changes in a single gene of one of those 30,000 genes that we have within our genome, or collections of genes that are known to be important and associated with certain genes, or indeed to use a technique called whole exome sequencing that enables us to look at those genes that are associated with an action within the body. But that's why we're able to think about genomics now in a different way in terms of value, as well as our ability to manage large data sets and to interrogate large data sets, especially given every single genome, for example, of an individual contains 3 billion letters, and then to use that an association with improved technologies for biomedical analysis. But there are a number of things that we have to do to make sure the system can respond to that. I go to my next slide, which just sets out that with all of this and with all of what I've set out in terms of the strategic direction that was set out in the NHS long-term plan, that's part of Genome UK, has been part of our history, has been how can we drive outcomes? And so we know genomics has the ability to improve human health and drive those more precision interventions, as I've talked about. But at the heart of this is really the recognition that comparing data with others, so data from individuals with others, is really going to be the game changer in terms of getting the best diagnostic outcome for individuals, or indeed the best outcome in terms of potential treatments that may be available. But what comes with that is the need for an infrastructure that's responsive to moving data and to tracking data, or the ethical and cyber security issues that all need to be considered. And then along the bottom, it's this whole recognition of discovery. So using genomic data with other data to inform the discovery of new diagnoses, new genes that are maybe important in terms of causing disease, and then with treatments in a way that brings partnerships with academia and with industry and with international partners. So it's a longer term dimension to the use of our data and to the security of that data. If I can go to my next slide. My next slide then just sets out about how have we driven transformational change. If I can go to my next slide. The context for implementing change in the NHS was we have had a long history, right back to the start of the NHS in the late 40s, of genomics being in some way within the NHS. But there were issues when we looked at how we wanted to implement change in about 2012-13. There was no national coordination and no measures of activity. Everything had evolved organically. We had escalating costs associated with the service. We had wide variation in inequity of access, and a lot of the cutting edge technologies only available in academic centres where there were academics with an interest. It wasn't embedded in end-to-end patient pathways, and the expertise was all focused in one clinical specialty, in clinical genetics. So in 2012-13, we knew we needed to change. If I can go to my next slide, this coincided with the launch following the London Olympics by the then Prime Minister of the 100,000 Genomes Project, a catalyst for thinking differently, a proof of concept study that was coordinated by Genomics England, that company owned by Secretary of State, but at a distance from central government, and a partnership with NHS England and other bodies such as Health Education England, with a focus on rare disease, cancer and infectious diseases, and where in NHS England we established 13 genomic medicine centres to recruit patients through routine care. You can see the principles there were for build the evidence for whole genome sequencing, so sequencing all those 3 billion letters in an individual's genomic code or the code of cancer tissue, recruitment through routine care, participants consenting to sharing of de-identified data for research and development and industry use, to establish a model for transformation and change and align research with that and discovery with that clinical practice. And a number of different outcomes on the right-hand side of this slide that I'm going to come back to. If I can go to my next slide, this summarises really the infrastructure, and NHS England invested significantly in this infrastructure, recognising this was part of a transformational change to the future for embedding genomics into healthcare. And on the left-hand side, through those 13 genomic medicine centres that covered the whole of the NHS in England, and the NHS England serves 55 million people, those centres consented patients, collected samples and data. They eventually validated and reported the outcome of sequencing and returned results to participants. And you can see there were nearly 90,000 participants at the end of the project, with over 111,000 genome sequencing, most in rare disease, but nearly over 37,000 in cancer, and that equates to essentially just over 18,000 patients, because both the patient's blood with cancer and their tumour tissue was sequenced, so we could understand the differences that would be occurring within their tumour tissue itself. And on the right-hand side, this is the infrastructure that Genomics England established: a biorepository for samples, a sequencing centre through a partnership with Illumina, an informatics architecture that created essentially a reading library rather than a lending library, enabling discovery forum users to look at that data, so genome sequence data, clinical data, and then longitudinal record data from the participants, given that's what they gave their consent to do, as well as establishing different scientific domains to actually look at the different diseases that were included within the overall study. And you can see there's now over 1.6 billion data points in this trusted research environment. There was the development of a semi-automated bioinformatics pipeline and a new way of starting to curate genes that might be of interest to look at when a genome was being analysed based on the presenting features of the individuals that were being sequenced. If I go to my next slide, just sets out that the project outcomes were informed by a number of different challenges. But if we look at the outcomes, it really did bring benefits to patients. It enabled the building of evidence in the future genomic medicine service. We had a large number of staff members involved in change. We had over 90% of NHS hospitals involved in recruitment. We established genomic multidisciplinary teams, and we better characterise the phenotypes or the characteristics of patients who are being sequenced, and then we standardised pathways. We enabled discovery and medical insights. In rare disease, the overall diagnostic outcome was 20% in all diseases, but that rose to 50%, for example, in eye diseases and in kidney disease. 50% of all cancer participants had a known actionable or potentially actionable gene identified. And then since the time that the NHS has looked at the results, fed those results back to clinicians and their patients, through that Diagnostic Discovery Forum I mentioned, 141 new diagnoses have been validated to be fed back to patients within the NHS by looking at in more detail at the genome. And at the moment, we're in the middle of feeding additional looked for findings that we can look for in a genome over and above what is associated with the primary reason that they're having the genome sequence done. So, for example, whether they're carrying the BRCA gene and they're predisposed to developing breast cancer. We're looking at those findings at the moment, feeding those back, and understanding the impact on the healthcare system. But there's also a number of outcomes in the way in which the programme was ensured to be ethical and based on consent, which included participants being involved in all of the discussions around access to the data, around a public dialogue, about the number of genomes that are within the reading library, and, for example, new ways of discussing consent and recontacting young people when they move from the threshold of their parents consenting for them into them consenting, given that the genome sort of continues to give and lives within a research environment. And then we kick-started a genomics industry, and we had 8 of the 10 top pharmaceutical companies involved in that discovery forum. To date, there have been over 160 publications, 550 registered projects within those different areas of interest associated with the disease, and greater than 1,200 scientific papers that reference both the UK Biobank and the GEL data sets. And importantly, we've developed key elements of the informatics infrastructure. So if we go to the next slide, what was really interesting was the impact on the Diagnostic Odyssey. In the middle here is Jessica, who'd gone around numerous different specialties before she got a diagnosis through the 100,000 Genomes Project. A defect was identified in the GLUT1 gene that was involved in the way in which Jessica would respond to different dietary requirements and the way in which glucose was transported across, for example, the blood-brain barrier. And so having a special diet reduced her epileptic fits, and she was able to not only live a better life, but because this was a de novo, so a new change within her genome rather than in her parents, it provided reassurance to her parents that future children weren't affected. But interestingly, on the left-hand side, we found that some patients spent 6 years attending over 68 hospital appointments before they got a diagnosis. And when we looked at that in more detail, that cost about 87 million to the healthcare system. And this can be changed by actually making sure that the healthcare system are both aware of the condition, but also by having whole genome sequencing available when there's no known genetic diagnosis for that individual. So severely reducing the time. If I can go to my next slide just summarises what we learnt from the project. It set the future vision and direction. It recognised we needed to coordinate services, commissioning and planning. It really showed up the variability of testing, especially in cancer, and how we needed a more structured uptake. It recognised we needed to standardise processes going forward and pathways, that we needed to be able to collate and capture high quality data to enable that data to be shared to make sure we got the best possible outcome. It recognised the value of structured whole genome sequence analysis at more of a national level and e-support for decision making, that end-to-end pathways needed to change if we were going to really drive the use of whole genome sequencing, particularly into the health service. It recognised the importance of clinical leadership and networking, and how the three pillars of the infrastructure were critical: the data, the testing, and the staff. And that we understood how we could start to use whole genome sequencing for additional findings. And although that's ongoing, it is providing us with learnings. So if we move on now to my next slide is about the NHS Genomic Medicine Service. So how are we implementing at scale, taking what I've just said, taking the strategic approach, and then implementing that across our National Health Service. If I can go to my next slide just sets out the strength of the NHS to deliver this. We've got a number of different providers, a number of different commissioners. We've now got integrated care partnerships, and 41 of those across England, that bring together the commissioners of services and the providers. But importantly, nationally, through specialised commissioning, we are able to provide, which is where genomics sits, direction and standardisation. We can address nationally inequity of access. We can use data to improve performance. We can link to those broader clinical priorities. We can rapidly adopt technology and mandate that, and use more of the collaborative working that's been strengthened by the pandemic. But what's really important in terms of the system delivery is we can work at that whole system level. We can access longitudinal health records if individuals provide consent, inclusive of primary and secondary care data. And as I've already said, we can use adoption at scale to drive efficiency and value for money. But you can see in the left-hand top bucket what this means in terms of what we're trying to create in terms of mainstreaming genomics into a healthcare system. If I can go to my next slide just sets out that in 2018 we launched our NHS Genomic Medicine Service. And this was really all around harnessing for the future the power of genomic technology and other advances to improve population and patient health. In that national level, in that specialised commissioning team, we commission and fund genomic services, and we're responsible for national oversight, assurance and direction. And when I secured the board's approval, I got a quadrupling, between a tripling and a quadrupling of the investment in genomics in the NHS. In terms of the infrastructure we've created, at the centre are now 7 genomic laboratory hubs, working across a geography, depending on where they are, of between 5 million and 10 million. So we get complete coverage, and coverage that can go from primary to secondary to tertiary care. We have a mandated National Genomic Test Directory that covers all the testing available. An ongoing partnership with Genomics England for the national provision of whole genome sequence testing, for bioinformatic analysis, for the underpinning informatics platform, and on the right-hand side there, for the continued curation of the National Genomic Research Library, enabling that ongoing discovery. And with our clinical genomics services and other teams supporting the clinical interpretation of both the outcomes or seeing patients with complex disease. Underneath, we have an ongoing collaboration with Health Education England for workforce development. And then we have 7 NHS Genomic Medicine alliances that are providing that multidisciplinary clinical leadership to embed. And you can see on the right-hand side are the key principles: clinically and scientifically led, patients and public involvement, equity of access, standardisation, model in terms of models of delivery and the contracting, responsive to change and innovation, and informing and driving change through data and evidence. If I can go to my next slide just says, and I'm not going to talk through this in any detail, is that National Test Directory has been developed looking at best exemplars from across the world. It covers from disease focus through to treatment decisions, a population-based testing approach, to predictive testing, to horizon scanning, so that we can eventually take on board all of the new developments, for example, in something we refer to as the functional genomics pathway, when we can look at how changes in a genetic code actually are translated and actually result in certain structures within the body and how those structures may be abnormal, and in fact the way in which drugs interact. And we've got an approach that leads from targeted testing for single genes through to panels for genes, through to that all the genes, through to whole genome sequencing. That's the genes and part everything else that makes up a whole genome. And looking in those other areas may be important for disease-causing areas. And we're in the middle, as I've said, of a live clinical service for whole genome sequencing. And as we move into phase 2 of whole genome sequencing, this will include, at the moment, the cancers include all pediatric cancers, sarcoma, and some hematological malignancy. Phase 2 that we're about to roll out will include triple negative breast cancer and high-grade serous ovarian cancer. And we've got and will have a total of 46 different rare disease conditions. And within these conditions, there are multiple different presentations. So it's not just 46, it's much greater than that. That are included. And this test directory is updated every year and can be updated within year, and it's mandated to the system. And to take account of scientific and technical developments, the cost and the way in which the testing is delivered, which is why we need to look at it across the whole continuum of testing. If I go to my next slide, this just sets out that one of our new and world-leading services is our rapid whole exome service, delivered for patients severely ill, neonates and infants. And we launched it in 2019. And you can see that we've had, up to October 2021, we've had over nearly 1,400 cases with a diagnostic rate of about 40%. So in 40% of cases, there's been a genomic cause. And this is done rapidly in less than 21 days, and you can see 93% are reported within 21 days. And on the right-hand side, there's been a number of different cases without a diagnosis that have then been uploaded to the Solve Rare Disease Research Study. That's led to, for example, 22 new disease genes and 12 publications from this study. So it's bringing it all together. So if I go to my next slide just says this service has had a significant impact on patients. And Ellie Rose here became seriously ill at 6 months. She spent a month in intensive care. That whole exome sequencing was used to diagnose a very specific genetic condition that affects fewer than 1 in a million people. And now doctors better understand her, how she's going to develop. They can monitor her condition and potentially opens up options for future research that could lead to better outcomes. And her father said coming home with a happy child was something we didn't know we'd been able to do so. So it's an amazing. And during COVID, from April 2020, we've opened this rapid whole exome service to include patients under 40 years of age with proven or suspected COVID-19, with features that suggest they may have an underlying immune disorder, or a disorder or collection of disorders that might make them more susceptible. And you can see that overall there's been a genetic diagnosis in 37% of those patients that fit into that category between the neonates and young infants through to that 40-year-old category. So really significant impact. If I can go to my next slide just sets out that we're providing more extensive cancer genomic testing. We're moving from single gene tests into extensive panels, covering all the different genomic targets that are important in different types of cancer. So applying them across all cancer types, and looking at both DNA targets, but also at RNA, at how they get translated and changed. And we're starting to look at how we link the gene panel access to early access to clinical trials, and that we fit the development of these panels with ongoing horizon scanning for new medicines. So this is a fundamental change and links with our cancer overall strategy in England, and with the way in which this will be driven through 7 genomic laboratory hubs, through lots and lots of, rather than through lots of pathology labs doing single gene tests or perhaps small panel tests, because this really opens up treatment possibilities. If we can go to my next slide just is an overview of whole sequencing implementation that I'm not going to talk through in any detail, apart from to say it starts with a discussion with the patient and ordering, and goes through different steps for the sample to be sequenced, the data to be analysed in that bioinformatic pipeline at Genomics England, coming back to the NHS for multidisciplinary team review, and then a report sent back to the clinician. There's been an informatics underpinning platform to enable that top line to happen. And so part of this has been testing the system, making sure the information and governance and data protection's in place, leading clinical transformation of clinical pathways and engagement of clinicians, and then the end-to-end testing of this with low volume of samples. But to date, we've had 8,000 samples through. But as you know, we've got a major target to get to 500,000 over the next couple of years. But this is now close to ramping up and is part of routine clinical service. If I can go to my next slide. My next slide just shows that this is really transforming patient care for patients like Fraser, where it brought an end to his Diagnostic Odyssey, where he'd had difficulty feeding as a baby and had multiple seizures, and it enabled connection with other families. In the patient B, this child had a brain tumour that was atypical, and after it had been removed, relapsed. And it was found to be the result of a novel genomic fusion that wouldn't have been detected by conventional technology if we hadn't used whole genome. The clinician was enabled to order inhibition therapy, and this enabled the patient to really progress and to get better outcomes. And then in polycystic kidney disease, which affects 1 in 500 people, we know that renal failure tends to occur often in middle age as a silent presentation, but the genes associated with polycystic kidney disease are quite technically tricky. And so therefore being able to use whole genome sequencing helps with predicting progression and treatment, and working out who needs blood pressure and kidney function monitored, and some of the reproductive options. And so far within the polycystic kidney disease patients going through the routine service, over 50% have a diagnosis. If I can go to my next slide. My next slide just sets out, we're putting patients at the centre with a new choice model, giving them clear and informed choice about the test they're having, the information to help them understand their choice, to cover both the use of their data within the healthcare system, as well as innovative use of their data to support and develop the service, with everyone given the opportunity to participate in research. And of those 8,000 genomes that have come from the patients within the service, 92% of patients have consented for their data to enter the research environment. And patient and public involvement now happens at all aspects of the genomic medicine service. And they're a key member of all governance groups and with ongoing dialogue as critical friends through the development of our service. If I can go to my next slide just says we're mainstreaming and embedding genomics through these 7 genomic medicine service alliances that are aligned to those geographies of the 7 genomic laboratory hubs. And their aim is to work at a system level with all those different components of the NHS I set out earlier, to provide clinical leadership, to drive transformation through projects that have been defined nationally and ones that are based on local need, and then that are linked to workforce development. And if I can go to my next slide just says, within the Genomic Medicine Alliances, they have a focus on end-to-end pathways and ensuring they look across the pathway and use genomics at each of these areas of this end-to-end pathway and establish them so we're not just using them at the point of diagnosis. If I can go to my next slide just says we've set out clinical leadership at all levels, and this has been critical. We've linked this to the clinical leadership competency framework that you can see in the middle, but we have national leadership within NHS England. We have a partnership with the Academy of Medical Royal Colleges that includes representatives of the nursing and midwifery Royal Colleges, between allied health professionals and scientists and pharmacists. Within all of our genomic laboratory hubs, they have a medical director and clinical lead posts for rare disease and cancer and corresponding scientific posts. And then we funded over 200 posts in the NHS Genomic Alliances to fund multi-professional leadership, including a clinical director, other medical, nursing, scientific, pharmacy and allied health professional posts. And then we've established networks to work with primary, secondary and community care and other networks, clinical networks in their area. If I can go to my next slide just sets out one of the transformation projects. And I just wanted to get across to you this is about integrated end-to-end pathways of care. This is sudden cardiac death being done in conjunction with the coronal system, with the British Heart Foundation, with the Royal College of Pathologists, and with the Health Education England and the Sudden Cardiac Death Charity. And it's to establish a consistent pathway from the coronal system through to genomic testing, through to testing of family members into inherited cardiac condition clinics, so that we've got this end-to-end pathway that happens and is systematic across England, and that we tackle the ability to reduce sudden cardiac death in relatives of those people who've died of sudden cardiac death. So they benefit from this knowledge. So that's just one example. If I can go to my next slide just sets out how important education and training is. We've got a pharmacy programme supporting the role of pharmacists. We've got a nursing and midwifery programme working with chief nurses to sustainably embed genomics into nursing and midwifery roles, and a medical programme, as I've said, working with the Academy of Medical Royal Colleges, and a number of different education and training interventions. If I can go to my next slide. My next slide says that we're delivering education at all levels, from formal training to those people working specifically in genomics, in scientists, clinical geneticists, genetic counsellors, to more formal education through master's level programs or modules or certificate programs, through session-based learning, through informal learning, through film and animation or fact sheets, and through awareness raising through information being available on website. And what's at the centre of this is interprofessional learning, formalising and developing the professions, establishing, supporting networks and trailblazing innovative approaches. And you can see the type of uptake we've had. And if I can go to my next slide, this is very specifically what we're doing at the moment, is developing bite-sized integration of genomic medicine into pathways. And this is a pathway for familial hypercholesteremia, that condition with high circulating fat levels, where there are genomic variants associated with displaying those high circulating fats, and where something can be done both at intervention and with family members. And you can see what we're starting to do in terms of bite size is identify at-risk individuals and the workforce involved, assess individual genetic risk, and determine what individuals are involved from the workforce. The same for family history, the same for explaining the test and getting consent, and the same for arranging genetic testing. So in terms of identifying the learning needs, this is defined in each of those areas. And what is required then to be embedded into the education and training plans for each of those professionals. And what it recognises is it's not the same for all. And we're doing this systematically across all pathways, starting with our national projects, which includes immunogenic diabetes, for example. And then we'll go systematically through all the conditions that are included in the Genomic Test Directory. If I can go to my next slide. Now, a key part of embedding is linking with personalised medicine. And if I can go to my next slide just sets out why there is a focus on personalised medicine. And it's personalisation across end-to-end, from earlier diagnosis to better diagnostic yield, to more precise diagnoses, for more effective treatments, recognising in England we spend over £15 billion on medicines each year and only 30 to 60% is effective, to drive fewer adverse drug reactions, recognising 1 in 15 hospital admissions are associated with adverse drug reactions, costing some 530 million a year, with the ability to monitor and understand recurrence, particularly in cancer, to drive the eligibility for clinical trials and research, and to identify predisposition markers. So that's why there's a focus. So it's bringing it all together. If I go to my next slide, it's setting out on my next slide, if I can go to my next slide, why there's a focus. There's been a focus. We've got thousands of cancer patients now benefiting from the introduction of something called DPYD testing for a certain type of chemotherapy regime, where people can have fatal adverse drug reactions. And also for new gene fusion testing to support independent of pathology cancer treatment, so going across a number of different cancer areas. So we've rolled that out. We're focusing on monogenic diabetes testing, so we can reduce the number of people who sit in that category who have to take insulin to control their diabetes. And then we're also focusing on new personalizations approach, is including a Grail partnership looking at early detection of cancer being piloted in in over 165,000 patients. So this is using a blood test, targeted sequencing to identify early cancer signatures that would lead to earlier diagnosis. And then we're in the middle of evaluating the rollout of non-invasive prenatal testing, giving patients more choice. So this is part of the reason why we've got a focus. If I go to my next slide just sets out, this will be eventually the end of one-size-fits-all medicine, where everybody gets the same medicine, into one shown on the bottom part of this approach, where people get a more personalised approach informed by genomics and clinical information. And we know that the top is more trial and error medicine. And as I said, typically only 30 and 60% effective. So it will enable us to tailor treatment to match an individual's makeup. And we set out in 2016 a 10-year improving outcomes framework for personalised medicine to improve prediction and prevention, to really drive that more precise diagnosis, to target interventions, and to have a more participatory approach by our patients and our public. If I can go to my next slide though just points out that to implement pharmacogenomics, so looking at drugs and genes more systematically, we'll need to take a range of different technology approaches, as shown on the right-hand side here, but then really work through, and this is the work that we're doing at the moment, the clinical use cases, what the workforce implications are. Do we really have the digital infrastructure, including decision support, to enable this to happen and to be effective at a primary care level? And what the cost effectiveness and affordability of this is in a value-based sort of chain. But that's a piece of work that we're currently working on. If I can move on now to my next slide. But what we know is when we get it right, as in the case of Lee Morris, who had a rare inherited retinal disease, received gene therapy and could see again. How fantastic is that? If I can go to my next slide, I'm going to change now into research driving clinical improvements, and I'm towards the end of my lecture. And if I go to my next slide, this just sets out that we are established and have established a virtuous circle where we use data from the healthcare system to inform research, and that research outcomes then inform healthcare. And this is through the NHS Genomic Medicine Service research collaboration. It includes NHS working with Genomics England, who've got the trusted research environment, and with one of our national funding bodies called NIHR. It really focuses on the innovation pathway shown at the top end of this slide, from discovery through to translation, adoption and diffusion, and how we can make this virtuous circle move as quickly as we can. And part of this on the right-hand side is enabling industry and researchers to bring projects that can be considered for implementation in the health service, access to patients, samples and data, and for that data to come back into those projects, be part of the trusted research environment, and that ongoing curation and annotation of a national genomic research library. If I can go to my next slide, there's a number now of different publications that have come out of the 100,000 Genomes Project and the work that we've been doing in aligning clinical care with research to support implementation, in this instance, of whole genome sequencing. If I can go to my next slide, it sets out, these are a number of examples of how research has driven clinical improvements. From 100,000 Genomes Project, we had a number of patients enrolled with blood disorders. What we established was how we could characterise those patients, how we could discover new genes associated with those disorders using whole genome sequencing, and how we could align the clinical service with the research. And you can see that there's it refers to one of the Nature publications that came out. And from a clinical translation perspective, this meant we were able to design and validate large gene panels for blood disorders that could be implemented across the NHS. It enabled us to coordinate the providers of the testing within our genomic laboratory hubs, leading to standardised reporting, data sharing, and multidisciplinary teams acting at a national level. So real clinical translation. And from a COVID research perspective, initially, COG UK, which was established in 2020, did the first batch of whole genome sequences funded by research. They sequenced over 500 viral genomes before it was taken over by the National Testing Programme and funded as part of a service offer. That informed, at that stage, the numbers of transmissions, the imported strains, the cause of outbreaks, and it was linked to our national testing strategy for asymptomatic, for symptomatic, for outbreaks, and for our borders control. And that's shaped our National Genomics Programme for viral sequencing that I'm co-directing. And then research also funded a study called Genomic to sequence the whole genomes of up to 20,000 people critically ill with COVID and 15,000 with mild symptoms to explore the genetic determinants of why they may have developed, for example, quite severe COVID. And we know the results from that study have identified different regions associated with severe, different genomic regions associated with severe COVID. And some of these have identified potentially treatments which are now being tested in different and ongoing studies, such as the recovery trial in the UK. If I can go to my next slide, this just stays with viral sequencing and said it started as a research consortium establishing the regulatory, laboratory and bioinformatics workflows, pipelines, tools and documentation and early proof of principle. And then it transitioned at the beginning of this year into a new programme within the National COVID Testing Programme and to deliver all the applications that I've just mentioned. And then by April 2022, when we will have over the ability to sequence over 100,000 viral sequences a week in the UK, it will transfer into the new public health agency called the UK Health Service Authority. It should be Security Authority, with more explicit service delivery, but into a fully functional and nationalised pathogen genomics network that will be enhanced and supplemented. If I can go to my next slide. And currently, the UK is ranked second in terms of the volume of sequences that have been uploaded internationally at just over 1.2 million sequences, constituting about 12% at the moment of all our cases of COVID. And at times that's been that figure has been variable. And we're at the moment trying to move towards sequencing 20% of all positive cases, and indeed to all viable cases if we possibly can. In the NHS, we sequence all possible viable cases of COVID-19. So if I can go to my next slide just summarises then what the future holds. If I can go to my next slide, which says we've got a number of challenges to overcome. We've got to change all those end-to-end pathways that I outlined. And some of that includes developing genomic literacy and upskilling clinicians that are in the existing workforce, involving all the NHS organisations. We've got to work within an ethical framework and at the pace of public acceptance. And we've got to make sure that our consent and choice materials are appropriate and give people all the information they need. But we have to recognise that the ethics can be dynamic, and we've got to answer big questions about when it's appropriate to carry out whole genome sequencing within the life course, when we reanalyse, how frequently. We need to retain public trust and create a societal contract for people to share and contribute their data, but based on reciprocity, altruism and solidarity. And then we've got to ensure there's appropriate governance. We need to make sure that our data, genomic data, reflects the diversity of our population. And we need to work further to make sure that our populations and the people in our populations who should access genomic testing actually can access that in the spirit of the NHS, free at the point of access for all. And then we've got to continue to develop our workforce. Just finally, if I can go to my next slide. My next slide just outlines where it could take us. Cancer testing routinely offered to all cancer patients and using a range of technologies so we can really exhaust whether cancer is associated with a genomic change. Introducing polygenic risk scores to assess the risk of developing future health problems, enabling preventative treatment and linked to other risk tools like those used in cardiovascular disease, where we use point-of-care genomic testing more at the bedsides or closer to the patient to rapidly inform treatment options, where genomic data from literally thousands of patients are stored securely and with consent and used by researchers and by industry collaborators to help develop new treatments, to end that one-size-fits-all and really truly personalised treatment based on those end-to-end pathways, to use genomics where it's appropriate to routinely diagnose common conditions, including cardiovascular, neurovascular, endocrine, to enhance viral and pathogen sequencing to make sure that we've got future pandemic preparedness and we can spot trends early and track them in the same way, for example, you might track hurricanes. And then a new development that we'll be introducing next year in conjunction with Genomics England is in a pilot study is to use whole genome sequencing in newborns to test for rare diseases early so that we can enable earlier interventions, particularly given that the outcomes under the age of 5 can be poor for certain rare diseases. So it's really a genomically enabled future. So my next slide just says, what we really have to do, and this goes back to something that Eric Topol set out, and I mentioned him early on, is the whole genome sequencing or even different types of genomic testing for single genes or for how it's translated into messenger RNA or how it's translated into proteins. All of that is going to be important. But for an individual, we're going to need to start to bring multiple maps of the various different parts of that functional genomics pathway so we understand what a change in DNA actually means, but really couple that with information from imaging, from other types of testing. So we build up this picture of the human paranome and link it with sociological and other epidemiological data. That's the future. If I can move to my last slide, my penultimate one, is we can only do this if we build successful partnerships. We work together and we work together internationally. And I really look forward to ongoing partnerships with Canada And there's lots we can do to exchange information, share data and best practice, establish evidence synthesis, agree common standards and outcomes, exchange and enhance the interpretation of complex information, and then communicate and engage and really drive this innovation pathway in conjunction with initiatives such as the Global Alliance for Genomics and Health and the Global Genomic Medicine Collaborative that Canada has played such a key role in, as well as the UK and other countries. And then finally, my last slide, when we get it right, and we get it right for individuals, this means there's no holds to what they can actually do. And this is just a British tennis player with a rare condition who was told she'd never play tennis professionally, but qualified for the Australian Open. What a brilliant and fantastic way to finish the Don Ricks lecture with how we can use genomics to really make sure that people can reach their potential. Thank you so much for inviting me to give this lecture. It's been a real privilege and honour, and I look forward to your questions. Thank you very much.
Thank you so much, Sue. What a remarkable journey and what a tour de force since 2012 when it started with the 100,000 Genome Project. And when you kind of laying it all out, it looks all very straightforward. But I'm sure that there were big barriers, big challenges to overcome, and we can only benefit from all the lessons that you have learned. So we have about just under an hour to have a conversation that will be informed by questions asked by the audience, and so I look forward to this. And so let's start with the first block of questions that go around the adoption of similar systems in other healthcare, in similar approaches in other healthcare systems. So one of the questions that is on Slido is that many countries are at the stage the UK was years back, and we know about the benefits of genomics. We know about what it can do in rare disease and pharmacogenomics, etc. But how do you develop the political will to actually start that journey and to go there and to take that risk to adopt new technology into the healthcare system?
I think partly, the argument I used, and it's something that I often say, is it's really important to be able to articulate the value and the contribution to efficiency and productivity. When I made the case to the NHS England board for increasing the investment in genomics, one, it was because there was an unmet need, and it was linked to poor outcomes. So I was able to show, for example, access to cancer genomic testing and the mortality outcomes in different areas of the UK. That was one area. The second is I was able to demonstrate that by continuing to take just an adding single gene approach to our testing strategy, it was costing us more money. Each year we were adding $1 million to our sort of overall cost bill. And we weren't getting a more equitable system for the country. So part of what it was to set out how we could introduce a system whereby we reduce duplication, we use technology to really drive change and to stop doing all the things we didn't need to do, and that we could couple it with all of those other priority outcomes for improving outcomes. So it was outcomes showing there was variability in quality, in outcomes in terms of mortality and morbidity, and it was showing cost. That was really a key driver. I think a key driver at a political and strategic level is still wanting, because of the long history of genomics in the UK, and that's why I started with it, that's been a key driver for the interest of politicians, and that link with wanting to drive the life sciences industry and to keep the UK at the top of the list. But what has been the more interesting conversation is one: how did I secure a tripling or quadrupling of the budget? And that was, as I said, making that case around quality stroke inequality, outcomes, poorer outcomes, about increasing costs because we didn't have our delivery model right, and that if we did this, what else we might be able to save. That was all a critical part of how it was, how it drove the change within the health service, and I got it into the place that we're in now with the genomic medicine service. But it isn't easy. It isn't easy, but it's about having the narrative and the evidence on which to base the narrative. I think there was also at that time a view from the very top of the NHS that we wanted to make the NHS a world-leading healthcare system in genomics as well.
So I want to get back later to the evidence, which is always a challenge, because you can show certain data, but then you also have to establish correlations. And it's also, from what I understand, when the 100,000 Genome Project was supported by the then Prime Minister, it was also motivated by his personal experience of having a child with a rare disease, which just shows how personal it all gets. And that's now being translated into personal experiences of the people throughout the system. So one of the challenges that we see quite often in our conversations with the healthcare system is there's a certain envelope from a budget point of view, and the people responsible for the healthcare system are often afraid of, okay, how can we add cost on one end, while at the same time not being able to eliminate cost at the other end. So let's say you're adding pharmacogenomic testing on the one end, but till it takes effect, we still have all the cost of the adverse drug reactions and the wastage on drugs. So how did you make that argument to make that investment on the one end and kind of waiting for the results to happen at the other end?
So, I mean, got quite a complicated question there, Pascal. What we know, and one of the reasons why, and I'm going to start with a different response, but one of the reasons we haven't introduced pharmacogenomics, because we've done a lot of work on looking at drug-gene pairs and interactions, is because at the moment, until we can really agree what the clinical use cases will be, the cost is likely to be prohibitive, apart from in areas like DPYD, which I mentioned, which is associated with toxicity to a class of chemotherapy agents called the fluoropyrimidines. We were clearly able to show that people were dying as a result of getting this treatment and having an adverse drug reaction. So in that instance, what drove the investment was not the cost effectiveness, it was actually the quality outcomes for the patient. I think it just goes back to the point that I made earlier, that it's multifaceted in terms of how you make a case for the investment. And some of the investment is taking out certain tests. And what we were doing is a lot of tests for a small number of people. And so it was gathering all the evidence to know where we should affect change. But also, for example, we have in England, we have a national cancer tariff, which means every organisation or commissioning organisations gets a payment that included their genomic cancer testing, and we extracted that money out of the national cancer tariff so that we could bring all of that money together, because what we knew was that because it was down at a level of aggregation across the whole of the NHS, and we have, some 220 different hospital conglomerations, many more GP practices, we knew that because it was being done at such a low level, it wasn't getting done. And so if we removed it from tariff, we could actually deliver more testing. And that's the type of work we've had to do over quite a number of years to get to the level of investment that we've actually done. Does that answer your question, Pascal?
Yeah, I certainly think so. I mean, it is, as you say, it's a complex area, and you kind of going into the budget and doing reallocations of budgets just shows how deep you have to go to make these things work. And you mentioned international cooperation, and there is the question on Slido about the Canadian healthcare system. But I think I'd like to generalize that question a little bit. So you're trailblazers in the UK, but what do you see internationally, and where do you see healthcare systems that are going in a similar direction as the UK does? And have you learned any lessons from other healthcare systems as you were going along?
So for many, and Pascal, I've had conversations with Genome BC, and I've learned a lot about some of the developments that you've done in cancer, for example. Also from Genome Canada with Catalina. There are snippets of information all over the place. So, for example, I often quote, and we're looking at the moment at how our approach for brain cancer, for example, in both paediatrics and adults. And what I know from St. Jude's in the States, in children's cancers, is that they take what I call a multimodality genomic approach to trying to find a genomic cause for the cancer in that individual. And by that I mean it's just the same way is sometimes when you're having sort of different investigations for some symptoms you may have. You may have a plain X-ray, you may have a CT scan, you may have an MRI scan, and you have a variety of different images that actually build up a picture of that particular, whatever that is within a body, that may be causing an individual a problem and may need to have intervention. And so I've learnt, and that's why it's shaping our multimodality cancer approach, and why I'm keen to move in to look at long read technology, so a different type of technology for whole genome sequencing compared to Illumina technology that is short read, so different technologies. But in brain cancer, for example, long read technology may tell us something more about something that's called methylation that happens in some cancers, that is the addition essentially of that are changes that happen at the transcription level, essentially. So I've learnt that. I've been out to Australia. I've seen their NICU PICU system, And we regularly correspond with Australia, not just on their Nuku system, but for example, on education and training. I've linked with NIH in the US on education and training, and indeed many different countries on education and training approaches. We look at different approaches, for example, in the Netherlands, for cognitive behavioural therapy. They actually have a model whereby their trained therapists actually work with the people with the more complex cases, and then they've embedded CBD techniques into other members of their healthcare team. And we're sort of looking at that as a model for genomic counselling. But I talk regularly to the Southern Island country, to the Spanish, to Brazil. I'm talking to many different countries, and I learn each time a little bit that I take back into the system. I work quite closely with Sweden, with the Karolinska, and through the different global alliances, the Global Alliance for Genomics and Health, or for the Genomic Medicine Collaborative. There are many countries, and there's always something that one can learn and take back into the system. And what I've been sorry about is, one, not only that I couldn't come to Vancouver to give this lecture in person, and then I could have visited many of the fantastic centres you've got, but secondly, I haven't been able to visit other countries where I really wanted to go and look at a very specific aspect of their service, whether it's rolling out whole gene, big gene panels in cancer, whether it's different approaches for rare disease. And although we like to think of ourselves in the NHS in England as world leading, we are, but in some areas we've still got a lot to learn from other countries. It's just we've brought it together in an integrated way within our healthcare system. We've got investment for embedding genomics into healthcare in a way across a system for 55 million people in our population.
So, would you consider clinical genomics a luxury? Or is it a necessity, and that kind of goes into the question, that can be implemented in systems that may not have the same resource availabilities as the UK does, or Canada for that matter? So is it a luxury, or is it a necessity that will find its way into the healthcare systems globally, irrespective of their resourcing?
So in terms of the projects that are being initiated across the world in genomics, I think in most, but not all, emerging in developing countries, and not most, a significant number, and in all developed countries, there are genomics projects, initiatives embedding within healthcare systems, but not as systematic as we've got in England. They're just at different stages of development. And you'll probably be aware that there was a recent WHO convened discussion on how genomics could be taken. This is across infectious diseases as well as human diseases, could be taken into developing countries, and those countries supported. Initiatives like the Global Medicine, the Genomics Global Medicine Collaborative, are supporting projects that drive genomics into those areas. I've seen some fantastic examples in South Africa and across Africa. And I think part of it is really understanding what is it that we can do with the technology that we've got available, or what can we do that is can be done on less expensive equipment, and with different approaches.
Yeah, I think it will be interesting. It goes a little bit back into the digital infrastructure necessary to do all these things. And one of the questions I would have is one of the one of the bottlenecks is the high qualification still required to apply these technologies in the day-to-day healthcare systems, and to what extent this expertise can at some point be replaced by digital expertise, which would make it much more accessible across systems. And is this something that you're thinking about?
Yes, most definitely. I think we constantly, what I would say is we never stop thinking about how we can improve, how we can do things differently, how we reduce the reliance on a workforce that is in short supply. And I think part of what we need to do is to really, really develop our artificial intelligence and bioinformatics pipelines. We have to find a way of sharing and federating trusted research environments so that we can safely share data. And we also need to continue. It's not easy when you get into a healthcare system with multiple different systems in laboratories, in clinical services, to actually link all that up together. And that's why we've gone for a platform, an informatics platform that sits above the EPR systems within our hospitals, but integrates with it. But that comes with different challenges. But I think we have to challenge ourselves in terms of when data becomes very complex to interpret. Is it that we create an international interpretation service? We already, for example, for some of our images, so we send data out to Australia, not because we don't have the expertise, but we just don't have the capacity in terms of being able to deliver those reports quickly. And to my mind, we have to look at each one of these potential disruptors in the system through the eyes of a patient or through the eyes of a member of our public. And that's because what they want is they don't want to be waiting 2 months for a result or for 28 days when they're trying to make a decision about their cancer treatment. They need this fast. And I think some people on this call, Pascal, will know I had breast cancer. I became a participant in the 100,000 Genomes Project, and I really understood what it felt like to be a patient and to wait for results when you've been given potentially a life-changing diagnosis. And it has really, I've always had a focus on the patient throughout my whole career. But in terms of genomics, one thing people will often hear me say is, what does this mean in terms of the individual at the end of this line? And I think, therefore, it's incumbent on us all who are leaders to think about any innovation that we can bring that means a patient and their family members can get a result as quickly as possible and as accurately as possible.
Yeah, it's introducing clinical genomics is a massive change management challenge in itself.
Yeah,
and that goes to the question on Slido. It's about the uptake. So we can have the best science, we can have the pipelines, we can have all these things in place, but at the end of the day, both from a patient point of view, but also from a healthcare professional point of view, they have to be brought to bear, and they have to be used in the most effective way. So how do you approach the change management within the healthcare system and in the interaction with the patients? That may be two different questions. So from a healthcare system point of view, how do you convince the participants in the healthcare system that this is the way to go and that they adopt it and tolerate quote unquote, the disruption of their traditional ways of approaching things?
So I think what you're talking about is healthcare professionals within the healthcare system. I think if you go back to my presentation, what I said we learnt in the 100,000 Genomes Project was the importance of clinical leadership and networking across geographies. What we've done through the Genomic Medicine Service we've introduced for the first time medical leadership alongside scientific leadership. So we've funded an infrastructure. We've also funded an infrastructure in the genomic service alliances that are driving that end to end. So, for example, we have genomic clinical senates that are brought together across geographies of about 8 million. So all the providers, representatives from different clinical specialties that come together. They get, and that's why we're taking that pathway approach to education and understanding who needs to have what. We're appointing genomic advocates, champions. We're involving medical royal colleges. We've got this clinical directorate sort of approach, and what I call it is often super regional, covering 10 million. So with a multi-professional leadership team that are going out into hospitals, that it's underpinned by education, by communication, by public-facing events. And we have our patients who are part of this system, who tell their stories. And the biggest single factor for change is the patient benefit. And we continue to bring together all of the stories on the benefits for patients, what it means in terms of accessing new treatments, how they can get those treatments earlier. And then by the type of conversations we're having with the National Cancer Programme, is how do we further drive this through, we have also cancer alliances in England, and how do we drive it by people who are also working in cancer? But it's engagement, it's leadership, it's the narrative, and it's showing the benefits for the individuals. And it's also weaving in those patient stories throughout this. And I have to say, I think we've been quite innovative in supporting through our Genomic Medicine Service Alliance. We've got 7 national transformation projects that include in sudden cardiac death. And imagine, previously having genomics, clinical geneticists, our genomic scientists, and others at the table with coroners, with the British Heart Foundation, with survivors of sudden cardiac death or people who've lost relatives, and with inherited cardiac condition clinics, so that we can change the service specification for that whole service. It's systematic. We're doing the same with monogenic diabetes linked to our primary diabetes prevention programme. It has to be that systematic. Otherwise, it just won't get embedded.
Yeah, and it's also the systematic approach ultimately drives equity of access, because otherwise you get these pockets of excellence and access to certain services that are not available to others. So do you actually also see that medical schools are changing their curricula and are adjusting to the things that you're doing in the healthcare system, so that the physicians come into the systems and physicians, nurses, etc., all come into the system better prepared for what you're trying to do?
It's a very interesting question, actually, Pascal. We haven't done so well at influencing the undergraduate medical curriculum, but we've influenced the postgraduate medical curriculum. We've done a better job at influencing the nursing undergraduate curriculum and what happens at a post-qualification level. For scientists, we've been constantly evolving, and I obviously have a big role in that, in changing and introducing new scientific programs. And we've done that. We've systematically introduced new programs for genomic counselling, including sort of a consultant level 5-year training program. And we've done the same for bioinformatics as well, and established them as a true specialty within the healthcare system. Of course, genomic counsellors have, but they haven't been within a postgraduate scientist training program with that access to then another 5 years on the end. So we're doing that, but it's the reason the medical schools often give us for not being able to integrate it is we'll have to take something out. But some medical schools have done it, but it's not systematic yet.
Yeah, it's one of the it's part of the conversations that we are having, and for instance, we also were looking at how can we increase the interest in the whole aspect of genomics by, say, have all the medical students being sequenced and being confronted with their results, and there were considerable issues around that from an ethical point of view and from getting approvals for it. But I still think if we can get the healthcare professionals interested in their own genomes to start with, it would certainly be helpful to have them interested in the genomes of the patients and what genomics can do over the course of their professional career, because the ones that are entering the profession now will be confronted with genomics in a much more intense way in 5 to 10 years. I mean, this trend will continue.
Yeah, and Pascal, it's interesting. We have had medical students that have become genomic advocates and have worked within the system as part of their elective projects. So we've tried to be really creative about how we could include some genomic teaching, but we haven't given up. And we will continue to fight the battle. I think the fact that we've got it in postgraduate curricula, though, is really important. And that includes in the link to the curriculum for general practitioners or primary care physicians, whatever you want to call them.
Yeah, because that's where probably, arguably, if once genomics can find its way into the primary care system, that's when we get the biggest returns, because it will prevent patients from having to go through the secondary and tertiary system in the first place.
Yeah, exactly. But I think part of it has been opening up the access for primary care physicians to actually order genomic tests. Previously, they've all been in the purview of clinical geneticists, and part of the change from with the National Genomic Test Directory was opening it up to other clinical specialties to order, and some of the ordering can be done at a primary care level. And then those orders for tests are actually reviewed, and that's why we've got a medical leadership component that runs through our genomic laboratory hubs as well, so they can review some of the inappropriate testing, provide advice, for example, on access to whole exome sequencing for NICU-PICU patients, and all of those type of things.
So you mentioned in your presentation you have a number of patient stories, and one of the and that's obviously the evidence that it works in individual cases. Have you reached a point where you can show the actual return of the investments in genomics from a larger based patient outcome and healthcare outcome through the statistics that you're gathering? So can you start to show this evidence?
So certainly from whole genome sequencing, we're starting to get, we know our diagnostic yield, and I'm sorry, people often don't like using the word, it being referred to as a diagnostic yield, but I suppose a better way of saying it is a diagnostic rate. We know our rate is at about 40% and higher for some conditions. This is for whole genome sequencing that's been introduced into routine healthcare now, as I've said, from last year, and where we are actually reducing some of the other types of testing that we would do. So we continually remove duplication. And so, for example, in some conditions, whole genome sequencing is standard of care, as I said earlier. So we know that we are getting a pretty good yield, a pretty good rate out of those, but we are about to undertake a huge review of all of the genomic testing that we've instituted to understand. So, for example, in sarcoma, we know that many people might get a whole exome as well as a whole genome as well. What does it really mean in terms of access to treatments? And one of the challenges is collecting the treatment. So it's not just the diagnostic outcome, it's the treatment outcome. When we've got there will be a new research environment. A new research environment is being constructed at the moment for all the new routine NHS whole genomes. When that is established, because we'll get a longitudinal data pull from that, we can start to see in those rare diseases, and we'll have outcomes around Diagnostic Odyssey. How long have people been going around a system before they get a diagnosis? Or with cancer, because we're linking it to the cancer registries, we'll be able to understand what eventually happens in terms of access to second and third line treatments. So we're just appointing new members of the team to start to do this level of data interrogation. And one thing I didn't say in my presentation, but we've introduced patient level contract monitoring. Essentially, it means every single patient that gets a genomic test, we will have an activity data point from that tells us what genomic test they had, for what purpose, what was the outcome, and various other pieces of data like that. We will then be able to interrogate this data to look for outcome data, but I'm really keen that we look broader than a diagnostic yield, and we look to a treatment, to a reduction in adverse drug reactions if we can capture those, if it isn't about introducing a particular pharmacogenomic test for a particular drug, like the DPYD example I gave. So that's the whole piece that we're doing. We know the cost, and we can we know the workforce in every genomic laboratory hub. We can start to get some really detailed and granular health economic data out of what we're planning.
And it will be wonderful to see that data over time, because I think that will be a big motivator for other healthcare systems to go in a similar direction. And to produce all that evidence, you obviously need all the data. And so that's a lot of data. It's not only a lot of data, it's very diverse data. And so how have you managed to kind of build that data infrastructure in parallel as you're rolling out clinical genomics? And where are you at to kind of being able to integrate all this data and then use that data to produce the evidence you're looking for, and getting the feedback mechanisms that allow you to constantly monitor and upgrade the system as you go?
So part of it, we've had, and we still have, a big informatics and data transformation programme. And part of that programme is focused on the National Health Service and what needs to happen to link our 7 genomic laboratory hubs with all their providers across their patch, with all those EPR systems, so that they can all talk to one another, they can talk to pathology, and they're able to transfer data. We then have a system that's been developed by Genomics England that really is from the Genomic Laboratory Hub on into sequencing, bioinformatics, and then out into interpretation and back into the National Health Service. Each bit of that has to be tested and also tested for penetrance, tested to make sure the right algorithms are applied for the right condition, that the right information is returned, because at the point of, for example, ordering a whole genome sequence, metadata goes with that sample. So all of that and being able to track samples, track data, that's all part of an integrated National Genomics Informatics Management System that's been developed in conjunction with Genomics England. But there's a lot of work that's had to happen within the National Health Service to bring providers together across geographies, and also lots and lots of individual systems, sometimes 600 systems within a conglomeration of hospitals that need to be brought together. And then what's being developed at the moment, as I said, is it's being developed out, or being developed out, is that trusted research environment for the NHS data. So that's the next bit. What does that need to look like? What's the governance of that, and how does it link with the 100,000 genomes database for access? And then how do we get, when we get data out, how do we, before we get data out, if others are working on it, making sure the access and other arrangements are in place. But when it comes back out, what sort of checks and balances do we need to have, and reviews before anything goes back into a system? So there has to be a lot of informatics and data developments around data standards, data interoperability, the ability to send messages in the right way, the availability of a robust and reliable cloud-based compute resource, the testing of components, the ability to pull in all genomic data. So the plan is that we would eventually have a whole clinical genomic data store. And when individuals have consented for that data to be used for research purposes, then it will enter into a trusted research environment. And then we need to federate the access. So you bring different data sets together with, for example, people with similar conditions. So we've still got a lot of work to do in that space, and a lot of money needs to be invested in it. And that's part of our future plans for certainly 22, 23, 24. And that will give us this complete data store for non-whole genome sequence and whole genome sequence data, and when consented, a populated, trusted research environment.
That would be a phenomenal genomic resource for the UK, and certainly translates also in huge opportunities from an economic and industrial point of view if that data is made available from a research. I'd like to, before we in the last section of our conversation, I'd like to go a little bit over into COVID and some of the experiences you made in that field. But before we go there, do you believe that what you're doing in genomics and the paces you're putting the healthcare systems through makes that healthcare system overall better able to adjust to innovation and change, and that there are lessons learned beyond genomics to make the system more adaptable and better able to adopt innovation in general?
Yes, so because we've essentially adopted whole genome sequencing very quickly coming out of the 100,000 Genomes Project, I sit on something called the Accelerated Access Collaborative, which is about bringing innovation into the healthcare system rapidly, not necessarily in genomics, in many different ways, including in medicines, for example. And what we're using is what we've done in genomics in our NHS Genomic Medicine Service Research Collaborative, that way of working, as an exemplar for how innovation can happen at scale and pace within the healthcare system. And for big technologies, actually, rather than smaller technologies that are in some way easier to introduce. And I think everybody recognises what we achieved through the 100,000 Genomes Project in the NHS was transformation. What we've done with the Genomic Medicine Service, we've taken that to a whole new level. And it is seen as innovative and leading in terms of all the innovation work that we're doing in the NHS in England.
So do you see that also, that goes to a question on side, or do you also see that as opening innovation pathways for new genomic applications like single-cell genomics and spatial genomics?
Yeah, exactly. I mean, that's why we've created this, whether it's functional genomics, whether it's single cell genomics, we've created this so that we can, if we've got technologies that we need to test, that we will test them in the real world environment. We will collect the data. That data will be made back available to researchers or to industry. And what I want to do is open that Genomic Medicine Service Research Collaborative, open it up to researchers that aren't just in the UK. We're certainly working with industry that is not necessarily based in the UK, and taking forward new projects, especially when we've got small cohorts of patients with rare disease where there's an opportunity for the development of a new drug. And so it could reduce, the approach we're taking could reduce drug development costs, but also enable us to think about a new pricing mechanism for those technologies to be brought into healthcare.
These are all the consequences of the personalized medicine revolution, in a sense. It changes research, it changes drug research, it changes the way drugs are being marketed, it changes how healthcare costs are accounted for. So this is really the mega change within the healthcare systems, and where genomics is going is really leading that way towards that transformation. As we have you, Sue, I wouldn't want to miss the opportunity to talk a little bit about the role of genomics and the fight against COVID-19. And I mean, obviously, COVID-19 has brought genomics to the forefront. Sequencing, variants, mutants, PCR tests are all now in the common vernacular in society. To what extent did the work you did since 2012 and before prepare your system better to deal with COVID? Where were the benefits of having a genomic infrastructure that you saw?
So what's been really interesting is in most of our testing, we've had to stand that up from scratch, and by that I mean PCR or other types of of testing. In terms of viral sequencing, what we've been very lucky that we've had a world leading position in tuberculosis sequencing and in some other pathogens that have spanned beyond sort of the UK. And there was a quite an active set of researchers in infectious disease. And as I said right at the very beginning, what we were able to do from not necessarily linked to 2012, but linked to sort of several decades of work on pathogen sequencing, the COG UK, so the academic consortium, was able to stand that up pretty early, and to be able to supply the sort of the national testing program with information on variants, and then it switched over, and what we've essentially done from there is we've built out from expertise. So, for example, the Wellcome Sanger are delivering 50,000 viral sequences a week now into our national testing programme. We've got other parts of what was Public Health England providing that sequencing. But what really made a difference, and so that has really helped us move from what was an academic endeavour to start with quite a number of different organisations doing relatively small volumes, to being able to scale up and then wrap it round with quality and all the other things that we knew from genomics, in pathogens in humans that we know needed to be present, like a quality framework, like the sample tracking, the use of analytic platforms. That's all been really important, or establishing EQA schemes within this area. What it helped with enormously, though, is through that, it's leading into a broader conversation about pathogen genomics. But what it really drove is, I mentioned the genomic study, and being able to sequence whole genomes from humans and having a national sequencing centre that's there for the NHS, it enabled that genomic study to happen, to sequence those 20,000 sequences from severely ill patients with COVID, and those 15,000 from people with mild COVID. And we wouldn't have been able to do that at all if we didn't have the infrastructure that we put in place for the future, that we put in place back to start within the 100,000. And then we've continued with the ongoing relationship with Genomics England, but with the funding of whole genome sequencing for the healthcare system, and therefore some of that infrastructure. So in a way, it's helped, and that partnership with Illumina has been really instrumental in that. So that has enabled that. What I still think we need to do more of, we haven't looked yet at the variants in the viral sequences against the human genomes, and what's been found in terms of the genomic regions of interest that might actually confer the ability to intervene with treatments. So I think that's what it's enabled us to do. It's brought together the background in pathogen genomics with the strength in the academic community around infectious disease sequencing, with what we've been doing in human genomics, because part of my experience in human genomics is shaping our model for COVID sequencing now, but also our model for pathogen genomics as we go out into April 22. But it also enabled us to establish genomic and be able to sequence those patients.
Yeah, it's interesting because in Canada the experience was very similar, but a little bit from the other end. So the experiences in pathogen genomics, which you certainly had in British Columbia, was the BC Centre for Disease Control, and then the national effort through the CanCoGen, so the network established by Genome Canada to share the viral sequences, which were also ultimately uploaded on GISAID, where actually Canada has done pretty well as well, given the size of our population. So I think COVID has certainly shown the urgency of having the abilities to do that. And I think what you have done in genomics in the UK just gives your healthcare system a stronger muscle to deal with future pandemics as well, because what COVID has illustrated is how important genomics is to inform the public health response, but also to inform the treatment response and the vaccinations ultimately. So I think there is a very strong connection there. And we could certainly dig further there, but we have about 7 minutes left. And I really would like to kind of close off our conversation with a question around, you have now 10 years experience of driving that. So if you would have to give us a few pieces of advice on how to approach that in Canada, you know our healthcare system well enough. There are significant differences with it being a provincial jurisdiction and the federal system versus the UK, but still, what would be the key advice that you would give us from the lessons learned that you bring to the table, how we can catch up to what you're doing in England?
I think that there is. It's always a challenge, isn't it? Having a federal and then a provincial government, but not impossible. And in a way, we're moving in England towards having a more provincial input. What I would say is, one, within BC itself, I think the most important thing is to make sure you've got a consolidated delivery structure and a way of funding this from the province itself. Because without, what we've learned is, if you have a distributed delivery system, it does cost more money, and you need more workforce. You cannot drive the consistency that you actually need. So one, it's looking at consolidation, and whether that's different for rare disease, for infectious disease, which is a public health sort of service. And that will remain so in England, by the way. The sequencing will remain being done eventually within just the public health systems, although it will be slightly different in Scotland. So one, it's consolidation. Two, it's getting the leadership right and creating, I think, a national healthcare programme, which I think you've got, or a provincial healthcare programme that really can start to drive change at the level of the province. And then I think I said this yesterday, which is, I do think there needs to be a way of finding out how you could work across Canada with key leaders to and agree some principles, agree some ways of working, whether you can get to a common delivery model, whether you can get to common data, the data that's collected, so you've got comparability, and whether from a federal government you can actually get funding to coordinate that type of activity, because it does need to be coordinated. And I'm sure that's what Catalina's trying to do through Canada, Genome Canada. But that is what needs to happen. You need a single conversation that happens across the country, but with all the multiplicity of players. But what's important, and what we've learnt, and I didn't have time today to show you, is the level of governance and infrastructure at the level of a single genomic medicine service alliance or a genomic laboratory hub, because they bring all the providers together, they bring all the relevant players together, and there's an ongoing governance meeting. and sort of accountability back to the health system and the payers. And that's what's really been effective at driving change and bringing the decision makers together in the room with the people who are the providers. So that's just some reflections. And
Well,
also, don't and to make sure you reflect on where you've been with COVID and how COVID might influence what you do federally and what you do at a province level.
well, Sue, thank you so much. Thank you for your insights, and we'll make sure that this trip that couldn't take place this time around will take place in the future, so we can continue that conversation and we can continue to benefit from your tremendous experiences. It was a real honor to have you speak to us today, and I very much appreciated all your comments. And it's now my pleasure to hand it over to Dr. John Shepherd, the chair of our board, who will thank you more formally.
Thank you, Pascal. I just want to, before I formally thank Sue, make a couple of comments on some of the things she talked about. And I think she did a wonderful job today of talking about where the Genomics Project has been within the NHS, where it is currently and where it's going. And looking back on what she has said, I think that the fundamental strengths of the process, in my opinion, in the past were the tremendous level of political support, both in terms of political will and frankly in terms of finance, of the framework that was developed for an ethical process that engaged patients so that they could be aware and longitudinally followed with their consent, and the way that they looked, they being the NHS, at linking clinical and scientific data on both an individual and a population basis. So this has set the stage, as was talked about in some of the anecdotes she presented, for better movement of patients and their families through the healthcare system. What we have now, as she pointed out, is a system which is hopefully working in cohesion across the NHS to provide, and these are her words, standardized and high quality care. She gave us some wonderful examples, the pediatric and neonatal intensive care results where they had significant findings in 39% of patients, the findings in patients with severe COVID related to immune defects or unrecognized immunodeficiencies was extremely important, and then the issue of better cancer treatment screening, particularly as regards to drug toxicity. And again, quoting her words, she said, "We have now got mainstreaming and embedding of genomics within the healthcare system, and this is a key to full understanding and utilization." And then finally, she touched on going forward. And I think that there are a couple of things that stuck out to me in this regard. First and foremost is the role of education. And Pascal asked an excellent question about this, but I think it is really important that we understand the role of education. And I would particularly beseech the teachers and educators in the audience to think about how you will incorporate genomics into your curricula. And I would ask students who are watching at all levels to demand that this be done. You need to push for this to be in your curricula because it is something which is part of the future, as we are aware. Sue was very good at pointing out the need to continue to do all of this within an ethical framework and with public trust and public understanding, particularly as we've seen over the last 22 months. This is something which is extremely critical. And then she made a very tantalizing and I think interesting comment about the role of personalization. There was a comment which came up in the questions that we didn't have a moment to ask, which I think is an interesting challenge. How do we reconcile personalization with the role of population-based or randomized clinical trials, for instance, which have always been the hallmark of things like cancer therapy? So this will require a bit of a paradigm shift in the way oncologists, and I speak as an oncologist, look at these. So a tremendous talk, and I want to say thanks to Professor Dame Sue Hill. And as a gesture of our appreciation for sharing your insights today, I have this talking stick, which was carved by Coast Salish artist Jim Yelton. As you and many people are aware, the talking stick is used in many indigenous cultures. It is an ancient and powerful communication tool. The person holding the stick, and only that person, is designated as having the right to speak, and all others must listen respectfully. So this stick is carved within Coast Salish tradition, as I indicated. Every symbol on the talking stick carries tradition and history with it. This particular talking stick includes the thunderbird, the beaver, and the wolf. The thunderbird symbolizes creativity, creation, cooperation, persistence, and harmony. The beaver represents strength, vitality, courage, and health, as we all know from our experience with beavers. And the wolf, of course, is a symbol of intelligence and leadership. He's a leader of the people, and the wolf shows the strength in relationships and the importance of strong family bonds. So, Sue, I cannot, unfortunately, present this to you personally right now, but we will send it to you, and I look forward to talking to you when you are able to come to Vancouver, as Pascal has indicated. So thank you very, very much for your time over the last couple of days. We have greatly benefited and appreciated from all of your wonderful advice. So I'm going to hand it back to Sally now to tie up some housekeeping details for the event. Thank you very much.
And so this concludes our program. We hope you've enjoyed the conversation. We encourage you to continue the discussion by way of the virtual networking hall, which you will find under the Connect menu on our website. A reminder to please fill out the survey that will be arriving in your inboxes shortly. Thank you so much to our distinguished guest, Professor Dame Sue Hill, and to Dr. John Shepherd for his closing thoughts. Thank you as well to Genome BC CEO, Dr. Pascal Spothelfer, for facilitating today's Q&A session. And finally, and most importantly, thank you for taking the time to join us this morning. That's all for us. I hope you enjoy the rest of your day, and we hope to see you in person next year.